Hi, my name is Donna Lane, and for my practicum in NSC 860, I chose a clinical nurse specialist, Becky Dotson, to be my preceptor. My goal for NS60 is to become a better communicator. Improving my communication skills will assist me with time management and organization, which will improve the quality outcome measures for my unit. Additionally, I will be a more effective leader because I will be able to communicate and present ideas in a more structured fashion. Communicating the shared goal that the medical surgical nursing unit would decrease the number of falls from 20 to 10 by June of 2018 in a manner that would engage staff and hold them accountable will assist the unit in obtaining their goal. The end result will be a 50% reduction in falls for the unit. However, in order to achieve the 50% reduction, there will need to be improved compliance and better understanding of the Baptist Health High Risk Fall Assessment Scale. For my NSC 860 practicum, I chose to follow Becky Dotson, one of the clinical nurse specialists at our hospital. Becky has been a nurse for over 20 years and has been in her current role for over 4 years. Becky also has her master's in nursing administration, and she is currently working on obtaining her DNP. In the CNS role, Becky is part of teams and work groups that work on quality initiatives. The CNS is often the project lead when change is being implemented. They are in charge of gathering pre-data related to why the change is necessary, gaining access to evidence-based articles and providing them to staff related to why the change is supported, working with staff development to develop an education plan for the staff, and helping implement the plan and collecting post data to ensure the change is being implemented. The CNS also rounds on the unit and reviews data to ensure quality measures and changes are being implemented correctly. Identifying patients who are at risk and ensuring correct bundles are being documented and implemented correctly is a huge part of their role. Becky has to review so many charts each day, and she reviews patients who are at risk of developing a CLABSI, a CAUTI, or a HAPI, as well as fall prevention to ensure that certain documentation measures are met. And also she'll follow up and round on those units and follow up with the staff to make sure that all the measures are being met. And if they have any questions, she'll try to answer their questions at that time. I knew fall prevention was an area for improvement at our facility, and it was also an area for improvement in my area. So I was fortunate when Becky was given the team lead on the NDNQI Falls trial that our facility will participate in this year. It also gave me the opportunity to shadow her during the IRB process, as well as go to the research committee and see what the process is like to get projects approved and implemented, and also to be able to do a research project at our hospital. With the NDNQI Falls trial, our hospital will be compared to like facilities across the United States, and information related to falls and fall prevention will be shared. Additionally, she is also chair of the No Harm Fall Prevention Work Group. So I was very fortunate that she was very involved with the Falls Initiative when I chose her as my preceptor. One of the areas that I've observed that my preceptor excels in is getting staff to buy in. When implementing a new change, she educates while rounding by taking bedside nurses with her and the nursing care techs. She shows the staff at the bedside what she is looking for and why those areas are important. My preceptor is also great about sharing positive feedback along with the negative feedback when rounding. Her positive approaches, I believe, has played a huge role in helping decrease the number of falls on the medical surgical unit and throughout the hospital. Using the Plan, Do, Study, Act framework, my preceptor would help me through the falls policy on my unit and help me identify where additional training and or education would be needed. The PDSA framework was used to help identify where gaps were located and implement small cycles of change to improve on and measure on the unit. I scheduled a kickoff meeting with staff who were engaged and wanted to help decrease the falls on the unit. Prior to the first meeting, we sent out a short audit tool asking participants to review 2 patients who were identified as a high fall risk, which is a score greater than 13 on the Baptist Health High Risk Falls Assessment Scale. The CNS my preceptor acted as the facilitator of my fall prevention team, and during the meeting I presented last year's data and compared it to our data year to date, as well as what our goal would be for our current fiscal year. We also reviewed the chart audits and identified where we were lacking and where compliance needed to be improved. One area we quickly identified as an issue was communication between nurses and techs. Nurses were not reporting to the techs which patients were high fall risk patients. And when techs or nurses were going off the unit or on lunch, they were not communicating which patients were at high fall risk. There was also confusion related around bed alarms and which zones high fall risk patients should be in, and also if the bed cord was plugged in or not. The part of the call out system that rings out to the nurse's station to alert everyone on the unit that the bed exit's going off. Another issue was a lack of chair alarms as well as chair alarm pads. All of those were very quick, easy fixes that if I spent time and helped them and educated them on what was needed to be done and how to do it correctly, we should see an improvement. Additionally, nurses were confused about the newly implemented Baptist Health High Risk Falls Assessment tool and the nurse's clinical judgment piece of the tool. Bedside nurses were concerned that they would score their patients incorrectly, resulting in them getting in trouble. So we tried to clear up all that confusion. My goal would be for a standardized process to be developed that the nurses and techs could go through during bedside shift report to ensure that the bed exits were set on high fall risk patients, and patients would also be told during this time not to get up without asking for assistance and to make sure that their call out was within reach. With the help of the CNS collating the data and helping me learn how to collate it and utilizing the PDSA framework, the report tool will become user-friendly and value added to both the nurses and the techs. The tool will be used as a safety reminder to ensure that safety checks are in place to prevent patient falls, with the end goal being decreased patient falls and improved patient outcomes on our unit. The CNS and myself will hold staff accountable by rounding on patients with a score of 13 or greater on the Baptist High Risk Falls Assessment Scale. My time so far has been focused on fall prevention and improving communication. Since starting the fall prevention work and improving communication skills on my unit, the medical surgical unit has had one unassisted fall. So I'm very proud to report that, and we have also tried to celebrate those successes. Thank you for your time, and I have really enjoyed my practicum this far and this class. It's really helped put everything together. Everyone have a great afternoon, a great day.